So I'm very pleased to welcome everyone to Peggy Lillis Foundation's second ever State of C. diff Town Hall. During this town hall, we're going to be looking at changes in C. diff, epidemiology, treatment, stuff that PLF has been up to, basically over the past 12 to 18 months. As many of you know, part of PLF's mission is to build a movement to combat C. diff, and we do this through raising awareness, empowering advocates, and shaping policy. We've had an absolutely amazing year. We held the first ever FDA patient listening session in March. We launched a new website at cdiff.org, and we are midway through C. diff Awareness Month, and we are expecting to reach 20 million people, which is just very exciting. But for our town hall tonight, we have a great panel of experts who are here to share their wisdom and experience, including a patient perspective, pediatrics, general gastroenterology around C. diff, and also talking about the new microbiome therapeutics to prevent recurrences. So I'm really excited to get into this. So we have a very exciting packed agenda. As you can see on the screen right now, and we're leaving a lot of room at the end for questions and answers. So, I'm really excited to get to it. But before we do, I really need to thank Nestle Health Science and Seres Therapeutics for sponsoring this year's State of C. diff virtual town hall. They have been amazing partners to us, and we are so happy to have them as our sponsor for this year's town hall. And with that, I would like to introduce Robert Griffin, who's the Senior Director of Marketing for Nestle Health Science. He is going to share a welcome and a little bit of what Nestle Health Science is up to and how they've been working with PLF. So thanks so much, Robert, and I'm going to hand it to you.
So it's just really an honor to be here and join a very important discussion that we'll have the rest of, I guess, the next hour or so. And I'd like to personally express our gratitude to the foundation for organizing this event. The work that you all do in raising awareness around C. diff and advocating on behalf of patients is truly commendable and just so important. We're just so proud to support your efforts in improving the lives of those affected by this serious condition. And for me personally and professionally, Nestle Health Science is really in a unique position with its diverse portfolio spanning consumer, medical nutrition, and pharmaceutical businesses. And in particular, as I think about our pharma business, it allows us to leverage the expertise of Nestle overall, alongside our deep understanding of the GI tract, to develop and commercialize innovative treatments that help address really very specific unmet, rare, or orphan conditions such as C. diff. And its recurrence with really the innovation that Seres brought forward in VOWST. And our strategic collaboration with Seres and other biotech companies actually allows us to tap into significant synergies and leverage our existing therapeutic GI and medical nutrition organizations. And that helps us build on our strong relationship with specialists and HCPs, not only here in the US, but across the world globally. And today's town hall provides us all with a valuable platform to share knowledge, exchange ideas, ask a lot of questions, and discuss the latest advancements for patients and healthcare providers. And again, I'd like to express my sincere appreciation to all the healthcare professionals, researchers, advocates who are dedicated to improving the lives of patients with C. diff. Your passion and commitment are truly inspiring, and we're honored across both organizations to be a part of this community. And in closing, I'd like to once again thank the Peggy Lillis Foundation, Christian, your entire organization for this virtual town hall, and for giving us the opportunity to be part of this important conversation. Together, we can make a difference in the lives of those affected, and this is just a tremendous journey that we're on today and will continue to be on moving forward. And with that, I'd like to turn it over to Maryann, who will share with us a patient perspective of C. diff. Maryann?
Thanks, Bob. Can everyone hear me? Can you hear me?
Yes, we can hear you. Go ahead.
Okay, great. So Good evening. My name is Maryann Webb, and I am a patient advocate with the PeggyLillisFoundation, as well as a board member. The reason that I'm here tonight is that I'm also a C. diff survivor, and I'm here to share with you just in some more general terms what it's like to be a patient with C. diff and some of the challenges that we have all faced with this bacterial infection, and I call it a superbug, and how dangerous and debilitating it is, and how important the work is that Peggy Lillis is doing, as well as some new exciting developments in this field in terms of treating C. diff infections. When I was first diagnosed, I had a case of diverticulitis, which I had never had before. And I was hospitalized for that and given very strong IV antibiotics. At that point, within a few days, I was discharged from the hospital. And I would say about 2 weeks later, symptoms of C. diff hit me like a Mack truck out of nowhere. And I'm going to be careful to describe this, so I don't want anyone to freak out, but I'm also very honest and straightforward for those who really want to know what the C. diff experience is like on a deeper level. So I'm always available for those questions. The initial symptoms are something out of your worst nightmare. They include severe abdominal pain and a diarrhea that is not like any diarrhea that anyone has ever experienced. I even hesitate to call it diarrhea. At one point, I counted 20 times I had been to the restroom in 1 hour. So immediately vomiting started, the diarrhea, and then it just snowballs. So I went to the hospital. I was very dehydrated. I was admitted, and they ran a battery of tests, and they had tested for C. diff, and it was negative. Subsequently, I was released from the hospital and had to go back several times until at that point, I tested positive for C. diff. So one of the main takeaways from that is, and it continues to be, that the C. diff testing is not, there are a lot of false negatives, and it's just not sensitive enough. So I was allowed to go several months without any treatment at all for the C. diff, and boy, did it take root in my body. So again, I've gone through so many hospitalizations that I went through in 3 years. I received the same treatment each time, and that was Flagyl, which is no longer used. And then I also had vancomycin as a treatment. It's a very, very strong antibiotic, very difficult to tolerate. I was often on nothing by mouth within the hospital. I was completely isolated from my family because it's contagious. I was isolated from everyone. So imagine hazmat suits coming into your hospital room, and no one really being able to visit you. And to be honest with you, you're so sick, you don't need that anyway. But it sort of starts to add and pile on to this feeling of isolation, which I think many people now, having experienced COVID and seeing what it's like to be so isolated from your family or friends, just fellow human beings. It's very, very difficult mentally on a patient, a very sick patient who's in isolation, which I was for 3 years. So during that time period, I always thought that I would be released from the hospital and be cured. It was not shared with me that I think I'm going to round numbers, but it seems that it's a third of the patients that are treated for C. diff end up recurring. And with each recurrence, and the medical experts will speak to this, you're even more likely to recur. None of that information was shared with me. And then in addition to that, there are toxins spreading throughout your body. So there are certainly parts of my body that were starting to fail. And that includes all the way to your thought process and your ability to focus and retain information. So that was my story. I had repeated the same treatments over and over again, and there is no test for negative. So I was treated as a recurrence each time, but I actually never felt like it ever left from the beginning. You get the ease of your symptoms with vancomycin and maybe some pain medication that tends to slow things down a little bit. But maybe a week or two after that, it's back, but worse somehow. And you think it just can't get any worse. So I was at the end of my rope. I was skeletal. I was unable to function. I was unable to remember. I was unable to leave my house. I slept on the floor in the bathroom. I was terrified that I was going to bring this to my husband and my daughter. And I was alone most of the time. And I lost almost everything. I lost a lot of relationships. People didn't understand what I was going through, and how could they? Because I didn't either. The information just wasn't there. And then I started to get my affairs in order a little at a time, because I could feel my body giving up. And it was a long 3 years. If you can imagine, if you've ever had a colonoscopy and you have to do the prep and everybody says, oh, that's the worst. The worst part about a colonoscopy is the prep. Well, imagine that prep every day of your life. And that's it gives you an idea of how it's just wrecking your intestines, and you can't leave the house, right? You can't leave the bathroom. So it's a similar kind of idea, except it never lets up. And during that time period, I also had to have a double mastectomy with reconstruction. And a lot of people say to me, why don't you lead with that? My personal doctors that I go to. And I often just say, because honestly, it's nothing compared to C. diff that I had. So eventually I'm going to say air quote cure was an FMT. And in order to have access to the FMT, it was emergency use authorization only by FDA. I'm not approved for a treatment. And in order to be qualified for that treatment, you actually have to have a significant number of failures of the other treatments. So there's this sort of lunacy involved, to my mind, that a C. diff infection caused by, in many ways by the overuse of antibiotics is then treated with more antibiotics. And everyone sort of scratches their head and wonders, why isn't that working? The FMT worked within 8 hours of my receiving it. So I have a great deal of frustration for the fact that it was not offered to me at the beginning of my C. diff journey, where I would have had the 3 years of my life back, and my family and my friends and my house and my job. But instead, I suffered silently and lost almost everything until I got the FMT. So I became involved with Peggy Lillis because I had this, once I was cured and I started to get my strength back in my mind, I thought, this is insane that other people are going through this. And I'm well aware of the fact that I'm very lucky to have survived. And there are 3 times at least that I coded. So it was in my mind a bit of a miracle that I did survive. And I thought, I'm going to use my voice and talk about what it's like for us as patients in this need for information and better treatments and better testing. The really exciting thing that has happened with a lot of advocacy work and in particular series therapeutics, and another company, Ferring, that within the last 18 months or so, there are new treatments that have just been approved for C. diff. I didn't mention fidaxomicin that I was on also, but none of those treatments work, and fidaxomicin is a targeted antibiotic. So these new biologics that we have available now are really, really a great start to giving C. diff patients hope where there just was never any hope. I mean, if you keep receiving the same treatment over and over again and it doesn't work, it's the very definition of insanity. So with that, I'm always available through the Peggy Lillis Foundation. If anyone has any questions they would like to ask me personally without an audience, I'm eager to share my experience, and I'm also here to help anyone who needs to find assistance within the healthcare system in order to help them through the C. diff process. And finally, I would like to say that I think that there is a great void left with treating the C. diff patient and the mental health aspect of it, because it's a very humiliating, degrading infection to have. It's embarrassing, and you feel sort of betrayed by your own body and the healthcare system. So I like to offer my support to anyone who's affected by C. diff and working through it. So, maybe I can help. So thank you very much for your time. And now I'm going to pass it on to Stacy. Would you like to take it away?
Thank you, Maryann, for sharing your story. I'm sorry it was such a difficult road, and we are all very grateful for your persistence and ability to get the care that you needed and now serve as a model and an advocate for our friends and family and patients who have this truly debilitating disease. So thank you for sharing and being so honest. I am Stacy Kahn. I am a pediatric gastroenterologist at Boston Children's Hospital. I specialize in inflammatory bowel disease as well as C. difficile infection in children. And I perform fecal microbiota transplantations for children who have had refractory cases of C. diff. And I am the director for the Boston Children's FMT and Microbial Therapeutics program, and I'm very grateful to Christian and the PeggyLillisFoundation for having me here today to speak to you about C. diff in children. I need to be able to share my screen if you guys can unlock it. Christian or Aaron, I'm not sure if you can unlock the screen share.
You should be able to share it now.
Great. Great. Yeah. Sorry, my computer has gotten very mad at me with all the Zooms and the PowerPoint presentations. So we'll get started. These are my disclosures. And I just wanted to start off reminding everybody who's here, who's probably very familiar with this incredibly difficult bacteria, a little bit about the science and the medical part behind it. So C. difficile is a bacteria. It technically falls into the category of bacteria that's a gram-positive, which describes how it looks under the microscope when we stain it, and anaerobic, which is the conditions in which it lives, and bacillus, which is its shape. The thing about C. diff that makes it so incredibly difficult is that it actually has two forms. It has a spore, which I kind of describe as a seed. The seed doesn't do anything, it doesn't cause harm, and those seeds are very hard to kill. They're very resistant, and we ingest those spores, and then something happens to our gut. We get an infection, we get antibiotics, there's some other environmental triggers, as we talked about already. We don't always know what causes it, and those spores or seeds open up and germinate and become the live bacteria. It is this live form of the bacteria that produces these terrible toxins that cause the symptoms. And what's interesting, in particular in children, is that many infants are colonized with C. diff, meaning that they have it, but it's not causing any problems. Once children get up to about a year of age, we see similar symptoms to that we see in adults. Less typically severe, but we are seeing a slight increase in severe cases. And as Maryann said, it causes horrible belly pain, bloody diarrhea, fever, dehydration, weight loss. Children stop growing well. They can't get off the couch, and some of them start to have loss of developmental milestones if they're really not doing well. And in severe cases, we see this colitis, which is what you see in this picture down below. This is a picture from a colonoscopy, and it makes this pseudomembrane or yellow coating that causes the mucus people see. It can cause this toxic megacolon condition, which is a dilation of the bowel that is a life-threatening illness. It can cause sepsis, which is infectious complications that lead to changes in your vital signs. And this infection can even be fatal. And so it's really, really quite serious. I wanted to start off with a case of pediatric C. diff, and we see C. diff occurring in children anywhere from a year, but less typically in the youngest children, all the way up into adulthood. And this is a case of a 5-year-old girl who presents with diarrhea. She's got terrible urgency. She's got very bad stomach aches, and it all started about 10 days ago. Her parents report that up until this point, she's been incredibly healthy and had no medical problems. And initially they thought she just had a GI bug. They're coming to you because her symptoms are getting worse, and they're pretty sure they saw blood and mucus in the stool. And what really worries them is that she's had a few accidents of incontinence, and she's been toilet trained for quite some time, and she's worried about going to school, and she's worried about her friends, and she can't sleep through the night. So this is really quite impactful in her life and really affecting her quality of life. She saw her pediatrician 3 days prior and was told maybe she developed some new food allergy or intolerance. And so the family had stopped dairy and gluten, but obviously she did not have any improvement. Not surprising to those of us at this webinar, her test come back positive for C. difficile, and she started on vancomycin and feels better after a few days. And then her parents begin with the questions. How did she get C. diff? Will it come back? What can we do to prevent C. diff? Should she go on a special diet? Should she take probiotics? Unfortunately, tonight we won't have time to cover all of these questions in detail, but I wanted to give you some preliminary answers to help you start to explore these questions yourselves. And I'd again refer you to the wonderful new, really revamped and improved website for the Peggy Lillis Foundation, because they really have some fantastic resources. So this is a slide from the Academy of Pediatrics from a recent publication in the Pediatrics Journal. In fact, it just came out, and it is a really nice summary of the impact of C. difficile or C. diff infection in children. So there are an estimated 20,000 cases of CDI in children per year. So it is not an exceedingly rare condition. About 3 in 10 or 30% of those children will have a recurrence within 60 days. What's really unique about children with C. diff is that very often we cannot find a cause, and these are called community-associated C. diff. So these individuals, unlike we see in adults where they've had exposure to a nursing home or been on antibiotics, many individuals in this setting have not had any major risk factors. And we also know that this is incredibly problematic because new therapies are needed and there are no vaccines currently available. We also know that the risk factors for C. diff in children are different. So we often see that children will have antibiotics, but not always. Acid blocking medication can also cause the risk for C. diff to go up. The presence of a feeding tube, underlying medical problems, including inflammatory bowel disease, as well as cancer. And I apologize if you all are seeing a yellow stripe through my screen. I'm not sure where that has come from. To talk about C. diff treatment, I think this is really highlighting some of the challenges of this devastating illness. So antibiotics are the first treatment that we offer. As Maryann mentioned, there are several antibiotics that are available. Historically, children have been treated with metronidazole, which goes by the brand name Flagyl. And increasingly, we're seeing that that's not as effective. And I really try to reserve that only for non-severe cases. It's also quite difficult to tolerate. It causes a terrible taste and nausea and vomiting. So it can be very hard for children to take a medication that's causing worsening GI symptoms. We also have access to vancomycin, and in the past couple of years, we had approval of fidaxomicin as well. For children who have recurrent C. diff, we might try the antibiotic that hadn't been tried previously, a vancomycin pulse taper, which is a long course of vancomycin, or fecal microbiota therapies, such as FMT. Unfortunately, as excited as we are about these newer therapies, they're only approved for adults, and you'll be hearing about those later today. But this is a serious problem. We have 20,000 children. 75% are going to have a risk of recurrence, and we only have antibiotics or FMT, and these great new therapies may take another 8 years or more to come to pediatrics. So we need to think about that. You'll hear more about these later, but they include an antibody treatment called bezlotuximab and these live bacterial products, which Maryann mentioned, and you'll be hearing about again. In terms of C. diff preventions and tips, I just want to remind everybody that this is a very resistant bacteria, both when it is alive and when it is in the spore form. Hand sanitizers will not work. And in fact, they may be part of the problem that they don't get rid of the illness, the risk factors for the illness. So wash your hands, warm soapy water. We tell the little kids to sing happy birthday once or twice, and then they've hit their 30 seconds. We should also avoid unnecessary antibiotics. So please don't take antibiotics for a cough. If your doctor absolutely thinks you need them, then you should consider the course and ask for the shortest course possible. We don't want people avoiding antibiotics if they are truly indicated, but do be mindful. In terms of probiotics, I get a lot of questions, and unfortunately, the data showing that they're helpful hasn't really been substantiated in the long run. They probably won't hurt, and they may make you feel a little better. But in the long run, when you're trying to get your kids to take their medicine, it may not be worth the fight to try to get them to take one more thing. Importantly, children should not return to school or daycare until they're having about 2 stools per day. And I put an asterisk here because some children have a baseline of 2 to 3 stools per day. And as much as we'd like them to be formed stools, we know that sometimes it takes a few months for things to get back to normal. It's also really important that the child be continent when they go back to school, and hopefully have completed at least 48 hours of antibiotics. They should absolutely call their GI or infectious disease doctor if the symptoms return after stopping the antibiotics, or if the antibiotics have a lower dose. And of course, as a pediatrician, I always need to say something happy. And so I say, Eat the rainbow, which means eat your fresh fruits and vegetables. This is probably one of the most important things to repopulate the microbiome in the gut. Lots and lots of unprocessed food, cutting out all the junk and really getting back to the basics can help that microbiome restore itself. As Maryann highlighted already, there are a lot of challenges in treating C. diff. We see high rates of antibiotic failure. We see high rates of recurrence. Upwards of a third of patients will have recurrences. We know that the antibiotics, although they may treat the infections, do not restore a healthy microbiome. We're seeing increasing rates of antibiotic resistance. Antibiotics are really quite expensive. The antibiotic treatments are complicated and difficult. The minimum dose per day is 2 and sometimes up to 4 times per day. As I already mentioned, the antibiotics might not be well tolerated, and the probiotics, as great as they may or may not be, do not prevent recurrence. So my take-home message here is more research is needed, and of course, more advocacy. And I'd like to thank my FMT and microbial therapeutics team. It takes a village to raise children, and certainly takes a village to treat individuals who have C. diff. And so I'd like to just thank everybody on my team. If you have questions about pediatric C. diff or FMT and microbial therapies, we are happy to see patients for consultation. Our email is really simple. It's fmt@childrens.harvard.edu, which is staffed by my wonderful research coordinator shown in the upper right-hand corner, Abby Kaplan, as well as our phone number to reach out should you want to talk more about C. diff or support our research. And with that, I will look forward to my questions, and I'm going to pass it along to Dr. Paul Feuerstadt, who's going to be sharing more information about C. diff.
Okay, let me just share my screen. Thank you, Stacy, for that wonderful overview. 1 second. Get this. There we go. Okay, well, first of all, I'd like to thank the PeggyLillisFoundation for inviting me to participate this evening. It's a true honor to be here. My name is Paul Feuerstadt. I'm an assistant clinical professor of medicine at the Yale University School of Medicine and attending gastroenterologist at the PAC Gastroenterology Center. My practice is a hybrid, part private practice, part academia. So, so I have a little bit of a unique experience in my daily practice. What I was asked to talk about is the epidemiology and antimicrobials in C. difficile infection, and Stacy did a really wonderful job creating a foundation for what I'm going to talk about, and I'm probably going to go into a little bit more detail with regards to some of the topics that she brought up. These are my relevant disclosures. Excellent. So all of us are here tonight and this afternoon because we know C. difficile is a major problem for us and for our patients, us being the healthcare system and patients because of their experience with it. In fact, the Centers for Disease Control and Prevention issued a threat level of urgent for this in 2013 and then again in 2019, speaking to the significance of this. But just how significant is it in an adult population? The CDC, or Centers for Disease Control and Prevention, has what they call the Emerging Infection Program, or EIP. What they do with the EIP is essentially look at 10 counties throughout the United States that they believe follow the trends of the rest of the country. And across those 10 counties, they track data over periods of time. In this case, what we're seeing on this slide, 2011 versus 2017, and then they project numbers. For C. difficile in 2011, 476,400 people were estimated to be diagnosed with C. difficile within that calendar year. In 2017, we should actually be patting ourselves on the back. We're doing pretty well. The estimated number went down to 365,200. So what was really behind that decrease in incidence? Well, I'll point your attention to the gray and the white bar graphs. And Stacy got into this a little bit more briefly that I'm going to, which is the difference between healthcare-associated infection and community-associated infection. A healthcare-associated infection is any infection that has an onset greater than 72 hours after admission to the hospital or within 90 days of discharge. And what we can see is in 2011, there was a much higher incidence of healthcare-associated infections than in 2017. In fact, the proportion accounted for in 2011 was about 2/3, whereas in 2017, it was about 50%. What was behind this? Healthcare systems improved. They cut down on the incidence of C. difficile by better infection control, better antimicrobial stewardship, more aggressive therapeutics. So we can impact the epidemiology of C. difficile infection. But C. difficile is still a major player in the healthcare setting. In fact, it is the biggest and most popular of all of the healthcare-associated infections, accounting for about 15.5% of all healthcare-associated infections. In this study, the CDC looked at the incidence of healthcare-associated infections, and once again, we're doing pretty well. The incidence in 2011, compared with 2015, went from 4.0% to 3.2%. But as we can see from this slide, the most common types of infections essentially remain the same: pneumonias, surgical site infections, gastrointestinal infections, urinary tract infections, and primary bloodstream infections. Most importantly, though, if you look at the slide, you'll see significant decreases associated with surgical site infections and urinary tract infections. In fact, the proportion of infections that are associated with gastrointestinal sources went up despite the overall decrease. That increased from 17.1 to 21.3%. Of that 21.3%, about 3/4 was C. difficile. C. difficile is the most common healthcare-associated infection, more common than MRSA, more common than VRE. But if you ask the layperson on the street, if they haven't had a family member or friend who's had C. difficile, they wouldn't know C. diff, but they will know MRSA or VRE. And this gets into better education and events just like what we're having this evening. So what are some risk factors for C. difficile in an adult population? I like to think about these in terms of demographics, medication exposures, and environment. From a demographic standpoint, age over 65, female gender, any form of immune compromise, chronic kidney disease, HIV, inflammatory bowel disease, diabetes, all make the list. Medication exposures, antimicrobials are a key player here. But as a gastroenterologist dealing with an adult population, it feels like PPIs flow in the water, proton pump inhibitors, acid suppressive medications are absolutely associated with an increased incidence of C. difficile, initial infection, as well as recurrence of C. difficile, repeat infections in the future. Why? Well, we think there's a couple of mechanisms. What is the first line of defense of our immune system? Many believe it's our skin. What is the second line of defense of our immune system? It's our gastric acid. So when we swallow things, the acid is there to sterilize. But as we'll learn in a couple of slides, C. difficile is able to get through the gastric acid. So many of us thought it was the decreased acid, more C. difficile getting through. But what we learned more recently is that the acid suppressive medications actually impact the microbiome, or the microorganisms that live within our gut, that help give C. difficile a knockout punch or help resist it taking up residence within our gut. And then finally, the environment. The environment that people spend significant amounts of time in can affect their incidence of C. difficile. If people spend significant amounts of time in the hospital or skilled nursing facilities, they're at increased risk. Why? Well, basically because they're surrounded by other individuals who have all these other risk factors, and they're surrounded by individuals who potentially actively have it. So let's think about why it would spread so much in a healthcare setting. I want each of you to think about what happens when we flush the toilet. Not a popular topic. It's dinner time, but not something we should think about. Well, Mark Wilcox over in England looked at this. He had a bunch of individuals who had C. difficile move their bowels in the toilet. He flushed the toilet and he measured the aerosolization. And yes, the yuck factor goes through the roof. However, there was one intervention that was done to prevent spread. Put the toilet lid down. That works in our homes, but in hospitals, there are no toilet lids. So we can see that aerosolization can potentially impact spread of infection. I want you to think about your house and your home bathroom now. I want you to think about where your toilet is relative to perhaps your toothbrush, something that you might want to fix just in your own home. What about those nice, clean, crisp sheets that we see patients lay on in the hospital? Those white sheets that they lay out on the beds look immaculate. Well, what are they cleaned with? They're cleaned with sodium hypochlorite and peracetic acid. Plainly stated, bleach. How effective is bleach in killing C. difficile? Actually only about 50% effective. So another way that C. difficile can spread in a healthcare setting. Now, as I shift gears and start to talk about antimicrobials, it's really important that we dig deep on understanding C. difficile and understanding the infection itself so we can understand how we can target it best and improve outcomes. C. difficile is a gram-positive, spore-forming, anaerobic rod. Well, that's the scientific term for this, but let's talk about what this really is. And there's two parts to it. One part is called the vegetative phase, and that's the part that we as clinicians and patients think about most, because it's the phase that releases toxins. Toxins impact the bowel and cause symptoms. They can cause abdominal pain, diarrhea, nausea, fevers, sweats, among other things. The vegetative phase, the phase that releases those toxins, that can be impacted by alcohol-based hand sanitizers or gastric acid. Essentially, alcohol-based hand sanitizers and gastric acid wipe this out. Alternatively, the spore phase, this is a different type of phase. This is much more resistant. The spore phase, in fact, is probably resting on the desk or on your laptop or on your desktop right now. The spore phase is endemic throughout all of our society. The spore phase can last on dry surfaces on the order of 6 months. So how do we classically get C. difficile? Classically, what happens is we swallow that spore phase. It gets through our gastric acid because it's resistant to gastric acid and gets into our small bowel in the center of the abdomen on this figure. Within the small bowel, the spore phase converts to the vegetative phase, the phase that releases the toxins. That builds up an army as it heads towards the colon. The colon is the outline of the abdomen that we see in this figure. But I'm a gastroenterologist, and I'm a gastroenterologist who specializes in colonic disease. I think the colon is a brilliant organ. And the colon is a brilliant organ because the colon has its own defense independent of the blood defense system. And that defense system is the microbiome or the microbiota, the group of microorganisms that can help resist foreign invaders like C. difficile. Well, what classically weakens that microbiome or microbiota? Classically, it's antimicrobials such as amoxicillin, ampicillin, clarithromycin, fluoroquinolones, cephalosporins, and piperacillin tazobactam, the commonly used antimicrobials. But any antimicrobial can weaken our colonization resistance. Once that vegetative phase, once that toxin releasing phase gets to the colon, it can cause symptoms that we classically associate that we heard earlier in this program. One of the biggest challenges in adults with C. difficile, just like with kids, is recurrence. But it seems as though the adult recurrence rates are even higher. It's estimated that up to 35% of people who are treated initially appropriately for C. difficile will recur. And of those that recur, up to 45% will go on to recur after that, and 60% thereafter, as patients get caught in this vicious cycle of recurrence after recurrence after recurrence. So look, how do we treat this? The best place to go to consider treatment are the updated Infectious Disease Society of America guidelines, and they were updated in 2021. And they essentially said, we need to change what we're doing. We should put fidaxomicin as our first line treatment. An acceptable alternative is vancomycin in a 10-day treatment. And finally, as you've heard, the concept is that metronidazole is largely being phased out due to side effect profile and also due to ineffectiveness. How did we get here? We got here from the study that I'm showing you here. And let's ignore the bar graphs and let's just think about what this study showed. What this study showed essentially was that as far back as 2005 to 2007, vancomycin was superior or more effective than metronidazole. And since that time, we believe that that gap has only widened. So given the side effect profile and the ineffectiveness of metronidazole, it's largely being phased out as a primary treatment of C. difficile infection. What about fidaxomicin? Fidaxomicin takes a different approach. It's essentially the new kid on the block. It's targeted therapy. A very important concept is that antibiotics or antimicrobials, they control that phase that releases toxins, the vegetative phase, so patients feel well when they're on them. However, the spore phase is really not impacted by antimicrobials. So we need a healthy, diverse microbiota or microbiome to give it the knockout punch. But fidaxomicin has targeted therapy. So it targets C. difficile, has less of an effect on the microbiome. Therefore, it is associated with decreased rates of recurrence. And that's what we see from the data on this slide across 4 trials over the last decade. We see that fidaxomicin consistently is associated with similar initial treatment response rates to vancomycin, but recurrence rates are lower. So what about for that first recurrence? What do? Fidaxomicin is favored again in one of 2 regimens, either the standard 10-day regimen or 5 days twice daily, and then 1 tablet every other day for days 7 through 25. An acceptable alternative is a vancomycin taper with pulse. And finally, if somebody failed metronidazole initially, we could consider vancomycin for 10 days. How did we get here with the vancomycin taper? This is a very nice meta-analysis from earlier this year, essentially showing that if we just give a pulse of vancomycin every 2nd day, followed by every 3rd day, it doesn't really work well. It's about 54% effective. Whereas if we give a taper alone, finishing with once daily dosing, that works about 68% of the time. However, if we give a prolonged taper and then we give every other day dosing, followed by every 3rd day dosing, that can get us up to an 83% effectiveness. So if we give a taper, we should give a pulse at the end and improve the effectiveness. The other thing that the IDSA SHEA guidelines recommend is this special regimen where we give fidaxomicin 200 milligrams twice daily for 5 days, followed by 1 tablet every other day for days 7 through 25. Essentially, a standard dosing for 5 days and then a pulse thereafter. And that came from this study. And what I'll show you is that if you look at the 90-day recurrence rates, 90-day recurrence rates with vancomycin were 19%, 6.2% for the fidaxomicin arm. So really remarkable decrease in recurrence rates, and this should be considered as part of the treatment algorithm. What did they say for second recurrence and beyond? They weren't original. They said use whatever you haven't used already. They recommended consideration for fecal microbiota transplant. Dr. Sahil Khanna is going to walk us through that, and also bezlotuximab. And let's talk about bezlotuximab really briefly. Bezlotuximab is a fully humanized monoclonal antibody that binds toxin B. Plainly stated, this is an infusion that you get in your arm that goes to your gut and binds the toxin, minimizing inflammation in the gut and therefore decreasing rates of recurrence. And that was shown in these 2 pivotal trials, the Modify-1 and Modify-2 study. Once again, we see a meta-analysis since this was FDA approved, and we once again see very encouraging results across 13 studies and 2,337 patients. Recurrence rates in the group that received this antibody was 15.8%. Those that received placebo, 28.9%. So we see ways that we can avoid that horrible cycle of recurrence that so many patients experience. So in conclusion, C. difficile is a problem, although we're doing better. We're doing better because of educational initiatives just like what we're attending tonight. There are 2 phases of C. difficile, the vegetative phase that releases toxins and causes symptoms, controlled by antimicrobials, and the spore phase that causes recurrences and needs a healthy, diverse microbiome to give it the knockout punch. Within the IDSA SHEA guidelines, fidaxomicin is now favored, metronidazole is being phased out, bezlotuximab is an effective treatment option, but this is a great segue to introduce my friend and partner, Dr. Sahil Khanna, who's going to talk to us about fecal microbiota transplantation. Sahil?
Good evening, everybody. And I would say good morning from the other part of the world. I'm going to try to share my screen. Thank you, Paul. Thank you, Stacy, for setting me up for success for my presentation. And of course, thank you, Maryann. I have been in awe of the PeggyLillisFoundation for a while, and this is my first time speaking at a webinar. So Kristen, thank you very much for inviting me. I'm going to take it one step further. I'm going to talk about microbiome-based therapies for C. difficile infection. Here's a couple of disclosures. And I have one learning objective. I'm going to talk about how do we adapt and implement microbiome therapeutics for recurrent C. difficile infection. We'll start with the adult situation, an adult patient. We'll call him Mr. CD, gets a sports injury. And as we learned earlier, we get a lot of antibiotics in the United States and across the world. About 270 million prescriptions are dispensed every year. A lot of times we don't really talk to patients about that you could get C. difficile from this. It's very unfortunate. Antibiotics lead to further disruption of the gut microbiome. While the gut microbiome is disrupted, If somebody gets exposure to the C. difficile spores that we talked about earlier, the spores then germinate into a vegetative form that leads to diarrhea, dehydration, abdominal pain, and a further disruption of the gut microbiome. So how would Mr. CD be treated in today's world? For the first episode, perhaps we'd use fidaxomicin, as Paul talked about earlier. That does not disrupt the microbiome further, but does not even restore it. For the second episode, perhaps we use a vancomycin taper pulse. We add bezilotoxumab to that. Unfortunately, the rates of recurrence are high. And then our options are, you can restore the microbiota. You can use extended courses of fidaxomicin. You can use vancomycin taper pulse again. But for the most part, everybody would think about restoring the microbiota in that situation. And traditionally, we've been using that product called fecal transplantation, or the procedure called fecal transplantation. And there's some issues with FMT that I'll talk about. As Paul mentioned earlier, that's where all the guidelines come together. The American College of Gastroenterology guidelines, the ID guidelines from the US, and European ID guidelines all say, restore the microbiota, enough is enough. You've had 3 or more episodes of C. difficile infection. So what do we know about microbiota restoration? We know that efficacy is more than 85% to prevent recurrences. We know it's superior to standard of care antibiotics, meaning FMT works better than vancomycin alone. You can use fresh stool or freeze-thawed stool. It has similar efficacy. There's usually no donor effect on efficacy of FMT, but we still need to develop processes for donor screening and donor recruitment and standardize those processes. Unfortunately, we've had some more adverse events from FMT, and over the years, the FDA guidance has evolved, and currently the FDA says, yes, you can perform FMT for C. difficile under enforcement discretion if you source stool yourself. If you do source stool from a stool bank, then you have to perform FMT under an IND for C. difficile. And finally, we have a couple of standardized therapies that have now been approved for C. difficile infection. This is one of my favorite randomized clinical trials. This one looked at patients with recurrent C. difficile infection who ended up being enrolled in this study and either got their own stool back, so autologous FMT, or got donor stool back. If you look at the overall cure rates were 90% without relapse, about 60% in people who got autologous FMT. That's the cure rate for the antibiotics. But when you split the data and look at the New York site, the cure rates were similar in both the arms. That suggests that perhaps those patients who got autologous FMT either never had C. difficile or were already cured with antibiotics before they got into the study. So diagnostics for clinical trials are very, very, very important. So when you have to think about enrolling a patient for FMT or a microbiome therapeutic, your first step is to start an antibiotic to bring the active symptoms under control. Remember, microbiota therapeutics, for the most part, are not used to treat active infection. They treat the next episode or prevent the next episode from coming back. After you start somebody on antibiotic, the diarrhea improves in 3 to 5 days, and risk of recurrence after 3 episodes is about 60%. At that time, you start thinking about, you know what, I need to discuss recurrence prevention with my patients. Let's restore the microbiome. And you initiate a referral to a center that performs this, or perhaps prescribe a therapeutic that I'm going to talk about. Until the patient can get the microbiome therapeutic, one needs to make sure one prescribes enough vancomycin or fidaxomicin, and perhaps taper it to the lowest effective dose until the therapeutic is administered to the patient. So how do you discuss this with patients? You say, you had a diverse microflora, you got antibiotics that led to low diversity. At the same time, you got exposed to C. difficile spores. The spores germinated into the vegetative forms that led to diarrhea, dehydration. The antibiotics that we gave you, vancomycin or fidaxomicin, didn't really kill the spores. Unfortunately, vancomycin also killed useful bacteria. So there is a risk of recurrence up to 60% or higher after 3 or more episodes. And that's where if you restore the microbiota with giving bacteria from another person, that leads to fewer recurrences. Now, FMT in its current form has had many challenges over the years. One need to exclude donors with microbiome-associated diseases, obesity, IBS, neuropsychiatric illnesses, and there is a long list, cancer, chemotherapy, and the likes. One needs to test their stool for 30 different infections. One needs to test their blood for about 7 different infections and make sure they don't have any emerging pathogen like SARS-CoV-2 in them, which could again restore the diversity of the microbiome. Over the last 3 years, there have been FDA alerts, including an ESBL E. coli bacteremia alert where one person died and one became deathly ill from an ESBL E. coli that just colonized the donor. There have been cases of sugar toxin producing E. coli that have been reported, and the FDA has an alert for that. And the FDA recommends one needs to screen donors for COVID-19 and monkeypox. And with all of that, we've been doing FMT for the last decade, but it's still a very heterogeneous practice in terms of donor screening, stool processing, administration, and follow-up of the patients after they get FMT for adverse events. Speaking of adverse events, there have been several that have been reported after FMT. Those could be C. difficile related or could be FMT related, like IBS that develops in patients. Patients get transient constipation, diarrhea, and abdominal pain. If you do this with a colonoscopy, there are issues with sedation, perforation, aspiration, potentially. And several microbiome-associated diseases have been enumerated, but not necessarily related to FMT, including obesity, microscopic colitis, peripheral neuropathy. The one that we know for sure, which has happened, is the ESBL E. coli transmission and sugar toxin producing E. coli transmission that has been reported. So with all of this, there is a lot of unmet need in the current paradigm, meaning you're really not restoring the microbiome after the first episode. You're giving patients hope and say, maybe 20% of the time it's going to come back. Here's hope. After 2 episodes, you sell more hope and say 40% times it's going to come back. And after 3 episodes, you want to restore the microbiota with FMT. But FMT becomes unavailable because of a pandemic that's going on or because of your donor becoming sick and the several issues that have been outlined with FMT over the recent years. That's where we need to standardize our manufacturing processes, our administration processes, so that this becomes like usual medicine. And that's where the standardized therapeutics come into play. They need to be under good manufacturing processes. One needs to standardize donor screening, donor recruitment, preparation, retention, testing, handling of stool, diluent, use for stool, how do you filter it, how do you store it? One needs to catalog the inventory for these therapeutics. One needs to trade the recipient back to a donor for adverse events, and then standardize administration. And having done FMT for the last decade or so, I can assure you this is a very, very, very tedious process for anybody to maintain on their own. And that's where we now have FDA-approved therapeutics. The first one that was approved in 2022 was called Fecal Microbiota Live JSLM, formerly known as RBX2660, currently also known as RBL, and the trade name is Rebiota. This is a suspension of 50 grams of donor stool that's gone through all of these manufacturing processes in 150 cc's of rectal administration as an enema. Patients don't need to undergo a bowel prep. This was a randomized double-blinded control phase 3 study that had used a Bayesian analysis and borrowed some data from phase 2. Interestingly, patients with 2 or more episodes were enrolled, and any diagnostics were able to be used. The overall success rate was 70.6%, statistically different from the placebo success rate, which is the antibiotic success rate of 57.5%, giving us a 99.1% certainty that the difference is actually true. And has been FDA approved. It's a single dose, rectal administration, no bowel preparation, can be administered in the office. The story doesn't end at the primary endpoint, which was at 8 weeks. When we looked at the sustained primary endpoint, meaning the difference between placebo and RBX2660, it was sustained up to 6 months and longer. So these therapeutics not only provide you benefit up to 2 months, but beyond that also. This product also looked at including patients who had other comorbid conditions, such as inflammatory bowel disease, irritable bowel syndrome, diverticulitis, and other GI illnesses. Some of these were also immunosuppressed in an open label study. And here, of 300 patients that were enrolled, about 75% achieved success at 8 weeks. And of those who achieved success at 8 weeks, at 6 months, 84% had a sustained cure at 6 months. And this also suggests that patients who have comorbid conditions can get these therapeutics. That's the first therapeutic that's been out there. The story doesn't end here. We also need to try to exclude pathogens as much as possible, meaning exclude vegetative bacteria, viruses, fungal organisms, prions, and the likes. And that's where the second product that has been approved, which is an oral administration, known as Fecal Microbiota Spores Live, BPRK, also known as VOS or SCR109, and trade name is VOUST. This is a very interesting product. In addition to all the processes that I had outlined earlier, they also treat stool with 100% ethanol, that kills everything else, but the Firmicutes spores that are hardy to ethanol, they are left behind. This is an oral capsule that is administered after a gentle bowel preparation of magnesium citrate 10 ounces and was studied in a phase 3 clinical trial. Patients with 3 or more episodes were included. They had to have a diagnostic test of the toxin detection to be included in the study. And here we see 88% cure rate in the active arm compared to 60% cure rate in the placebo arm. Statistically significant, clinically meaningful difference, and is also now FDA approved as of April of this year. This is a 3-day dosing. Patients finish antibiotics. There's a washout period. You give magnesium citrate, and then they get capsules, 4 capsules once a day for 3 days, empty stomach, that they can do at home. Don't need to come to a doctor's office for this. There is another product that's in clinical development called VE303. I'll briefly talk about that. This is 8 bacterial species, does not need any donor stool. Put in an oral capsule, and phase 2 study demonstrated 86% cure rate in VE303 and 54.5% in the placebo arm. Now, a unique ability of this product is to recolonize the gut without needing bacteria from a donor. Also, in this study, they included some patients with 1 episode who were high risk for recurrence. So we're moving on earlier in the course of the treatment. And a phase 3 for this study, this product is planned. What about SER-109, which is approved and has longer term data? These are data that go beyond 8 weeks, which is the primary endpoint. And at week 12 and week 24, we're seeing sustained cure, similar to other products that have data for 6 months or longer. And safety was comparable to placebo through week 24 also. Just like RBL, VOS has also undergone a phase 4, or I should say phase 3 trial called EcoSpore 4, which had 263 adults. Now, this also included patients who had 1 or more recurrence or 2 or more episodes, moving it earlier in the course of the C. difficile treatment paradigm, and multiple diagnostics, including PCRs, were included, and people with comorbidities were also included. The data here are in front of you that suggest that there is a high cure rate in patients who have all of these comorbid conditions, suggesting real-world efficacy of both these products. So how far have we come with all of this? Lots of excitement. You can see for 3 or more episodes, now you've got 2 FDA-approved therapies outlined in green here, several in clinical development. For 2 or more episodes, again, you've got 2 FDA-approved therapies and several in clinical development, and one of them is in clinical development for 1 or more episode. So my take-home points, as we heard earlier, microbiome alterations are the key to the pathogenesis of C. difficile, and restoring the microbiome is the key to manage recurrent C. difficile. Please don't get me wrong, FMT is safe, FMT is effective, but has many, many challenges, and that's where we've got 2 FDA-approved therapies that are now available for us to prescribe our patients, giving them actual hope, an enema-based therapy, rectal administration, and also an oral therapy that people can do at home, and several on the way. With that, thank you very much for your attention. Kristen, over to you.
Well, thank you all so very much. I mean, that was just a ton of amazing information, and also a heartfelt story from Maryann. We do actually have, I mean, Sahil powered through that, and we actually ended a couple minutes early, so we do have time for questions. We have 2 that have come into the chat so far. One is, does taking antivirals, for example, Paxlovid, increase the chances, the risk of a C. diff recurrence? So Paul or Sahil, if you have any thoughts on that?
While Paul's getting unmuted, Kristen, we haven't seen a whole lot of data regarding antivirals increasing the risk of recurrent C. difficile infection. We have also not seen an increase or a decrease in C. difficile with the pandemic itself. A lot of people took Paxlovid during the pandemic. I think that is mixed up and still out there. This is probably still something that will need to be investigated going further, as we're seeing community-acquired C. difficile, where people sometimes get it without antibiotics, is do antivirals or antifungals or other medications impact that? I think it's still up for debate, but I'd like to hear what Paul and Stacy have to say about it too.
Yeah, in my clinical experience, it's exactly as what Sahil just said. Essentially, that there isn't sufficient data to make the association right now, but I think that it's something that we need to look into. It would be really fascinating to run microbiota analysis in somebody at baseline, then obviously when they're receiving Paxlovid, although COVID will certainly impact the microbiota also, and then maybe 3 months after, and then sort of integrate that into incidence. But that's a massive project that I don't know if we're going to be able to get done. Stacy, what are your thoughts?
Well, we don't see as many children getting Paxlovid as adults. The few that I've had who've taken Paxlovid, we haven't seen any increased rates, and certainly we haven't seen an increased rates with generalized COVID infections. Really, probably a whole different story with the virome, which is the viruses in and on our body, and they actually outnumber the bacteria by about 5 to 1, and that we know even less about. So hopefully in the next few years we'll have more to tell you, but I think right now the relationship between viruses and bacteria in our gut is poorly understood.
Sounds like there's more research needed on that particular question. Let me see. And then, so Jenny asked, does FMT have a positive impact on the absorption of vitamin D, and does it help improve blood sugar levels for cholesterol and sugar? I don't know if that's even been studied, but maybe you guys have any observations on that.
We can sort of wax poetic on it, but we can't make definitive statements. So what I will say with regards to that question is the microbiome or the microbiota has several functions that we're aware of. The one that we focused on tonight was colonization resistance and resisting foreign invaders or infections from proliferating, but it also has what we call metabolomic effects or metabolic effects. And those metabolic effects, if we have the right milieu, can help prevent various things or promote various things. So we know, and we've known for a long time, that the microbiota plays a role in various vitamin metabolism processes. So the answer is, if somebody is deficient and they receive a microbiota restoration, theoretically it should improve. The impact in patients with diabetes, the impact in patients with other, I'll say, autoimmune type diseases is something that we're still kind of assessing. Because we can't just put the cart before the horse. We can't just say, okay, well, you have diabetes and you have this specific type of diabetes, so let's just give you a transplant and see what happens. What we have to do is define the problem, and C. difficile was the landmark for this because it was really the first process that we knew that the microbiota played an important role, and we quickly defined it, and we were quickly, relatively easily able to have a lock and key fit on improvement or rediversification of the microbiota, reducing recurrence. With the other diseases, it's a bit more complicated because it probably isn't the primary process in most of those diseases, but a contributory. So essentially what we have to do now, and what we're doing now, is a lot of research assessing the alterations or the changes of the microbiota. We call that dysbiosis associated with the disease state. Once we define that, then we can target therapy.
I'll add to that, Max Newdrop, about a decade ago now, did a study where he took stool from lean people and gave it to obese diabetics and showed a modest improvement in glucose control. Since then, that has not been replicated. I think all of these other diseases are multifactorial. I also believe that perhaps going forward, we will probably see microbiome therapeutics as an adjunct to making a regular medicine work. So let's say if I'm diabetic and I take metformin, and all of a sudden metformin stops working for me, is that because of a microbiome that has now become dysfunctional and not allowing the metformin to work, and could we restore that? Those are questions that still need to be answered, and we're not there quite as yet, but there is definitely hope.
Thank you, guys. So next question is, post FMT, is the microbiome considered back to whole, or are you always at more risk for getting C. diff if there is a need for antibiotics down the road? This is a question we get a lot.
I'll take a first stab at that. Studies that have done in this realm have demonstrated that your microbiome gets restored similar to the donor. Now, once that is done, do you go back to your own environment and then does your microbiome become like your own previous pre-antibiotic microbiome? That is almost impossible to answer. The one thing that we have seen in our research is that the risk of getting C. difficile with future antibiotics is lower than somebody's gotten repeated antibiotics over and over again. So to put some data into context, we looked at people who got FMT and then the next 1 year got either antibiotics or hospitalization, and about 78% of them did not get repeat C. difficile infection. So it's much better than what we think it would be. And if somebody does need an antibiotic after FMT for a true infection, I would not withhold that, because if you withhold an antibiotic, then the chances are the infection could get worse and you get a worse antibiotic, or you get it for a longer duration.
Yeah, I'll echo Sahil's thoughts. I view microbiota restoration or fecal microbiota transplant or the live biotherapeutic product treatments as a reinforcement. So essentially, people who've had C. difficile in the past, that will always show up as a risk factor for the future. But if you received a microbiota restoration or a fecal transplant, I think it goes down much, much lower than if you did not. But we live in the real world and people require antimicrobials. And I completely agree with Sahil that if they need it as a heroic measure or a measure to control another infection, of course they should receive them. And then we'll kind of deal with the repercussions of that on the microbiota and whether or not they get C. difficile again. I'm sure Stacy has a different spin on this because of the population that she deals with. So go ahead, Stacy, what are your thoughts?
Well, I think you're absolutely right. It depends on the patient and the population that you're taking care of. In pediatrics, we've been very successful with similar rates of FMT success and engraftment, which means an uptake of the donor microbes. And it usually becomes a hybrid microbiome. And gradually over time, you eat the rainbow, you stay off antibiotics, and you get better. Generally, we look for about a 2-month window when we think you're most at risk for a recurrence, sometimes as long as 3 months. But in general, if you can make it beyond that 2-month mark, we're getting increasingly confident that your microbiome, without major changes, is getting healthier. Now, if you go out and eat a lot of fast food and you don't eat any of your rainbow and you don't take care of your health and exercise, then that isn't good for your microbiome, and that puts you at risk for complications. Obviously, if you have an infection, you need to take antibiotics. We will work with you to kind of manage that and the expectations. But I have many pediatric patients who've had FMT and had to go on antibiotics for other illnesses and do just fine.
I see. Maryann, did you want to add to that as somebody who has had an FMT, and I believe you've had to take antibiotics for something since?
So actually, yeah, I've had several things happen to me where it, under normal circumstances with a normal patient, I would have been subject to prophylactic antibiotics and surgery. So I've had several surgeries and dental procedures, and I discussed this with my physicians, with my surgeons, and I said, I did not want to have any antibiotics during the surgery. And they, you know, it usually ends up in a discussion, and I usually win, because I just feel like if I'm going to deal with an infection that comes from a surgery, I'll deal with it after the fact. But in all situations, in all of these surgeries that I had, I never once had an infection. So normally the anesthesiologist in the surgery would be giving you the antibiotics through an IV during that process. And I haven't had any issues. I was told that, you know, unless it's a life or death situation, I really just need to stay away from it. But it goes to show you how many times antibiotics are prescribed prophylactically. And we also know that it's in our food supply, et cetera, et cetera. So we are all, whether you know it or not, we're all taking antibiotics to some degree or another at all times, unless you're really just not eating. So yeah, that's something that I need to be very, very careful about. I have a question actually for the panel. And it's something I've given some thought to, and that is how, if we are not testing for negativity, in other words, you've been C. diff positive and you've been on, if you've been on you know, a regimen of vancomycin or whatever the case may be, there is no standard best practice, at least that I'm aware of, where you're going to test that the C. diff infection is gone. And so I have difficulty understanding where the medical community is drawing the line between a protracted C. diff infection and technically a recurrence. And the reason that's important to me is if some of these treatments are only available if they qualify as a recurrence, you're less likely to get that treatment until later on in the process. So at least that's my understanding, and it's something that I would like to ask all the medical professionals on the panel about.
So you ask a really important question, and I think you started us off in a very impactful way and a very relevant way, which is that diagnostics failed you initially, and diagnostics will fail us eventually. So we do not have an ideal test for C. difficile in a world where we want to control everything from our cell phone, and we can probably turn the lights on and off in another room right now, or whatever the case may be. We don't have a good test for C. difficile. So, and the test that's most commonly used in the United States is a single test, the PCR assay, is a test that has a high false positivity rate. In English, that means that if you were to test me right now, I would test positive, but if you had me on camera the whole time, I didn't run to the bathroom, meaning I don't have active C. difficile. So this is a limitation of the testing that we have. It needs to be clinically taken in a clinical context. So if we were to test everybody to confirm that they no longer had C. difficile, unfortunately, as I mentioned, the spores remain within our system, and it's the microbiome that keeps those under control from converting back to that other phase that releases toxins and causes symptoms. So we test positive for an extended period after we treat C. difficile totally appropriately and potentially cure it. So this is why we don't normally recommend testing to confirm that it's gone, because you'll end up actually testing positive most likely. And if you do, you would want to treat it. And if you treat it, believe it or not, a treatment like vancomycin can cause it. So it's a confusing answer to an important question, but an important question nonetheless. I'm sure the other panel members have other comments relevant to what I just said.
Thanks, Paul.
Well, I agree with you completely. Go ahead, Maryann.
No, I just said thank you. I appreciate it.
Yeah, I think you're bringing up a really critical issue, which is not only do we need research in treatments, but we also need research dedicated towards testing. And we know that a lot of tests for different infectious diseases are not perfect, right? Not just C. diff. We have issues with testing around COVID and other highly transmissible infections, and it really requires a lot more time and resources. In pediatrics, it's especially a challenge because in the first year of life, upwards of 60 or 80% of babies will test positive for C. diff. And by the end of the first year, it's down to 10 or 20%. And those children are asymptomatic. Now, does that mean there are no long-term consequences? We don't know. But it's really hard to create a testing scenario where we're really going to know what we're treating. And a lot of the pediatric research has shown that even with the ELISA test, which is the test that we often use in pediatrics, where it's looking for the toxin and another marker, there's not great sensitivity and specificity. And the reliability, even if we use a 2-step test where we do this test, and if it's positive, go into the next level test, even when we do that, we have a very poor ability to differentiate who has the disease and who doesn't, which is why it's also important to make sure that if you're not getting the treatment you need or the care, and you think that there's something going on, that you definitely get in to see probably a gastroenterologist, because these are GI symptoms. And so there can be other things that are causing GI symptoms. And so if you're not better on your treatment for C. diff, or you feel like your C. diff has come back and you can't get another test, but you're not sure what's going on, really, those are the times to reach out to specialists in the field. And this is where the Peggy Lillis Foundation can really help direct you to people who have really taken care of some of these more nuanced cases. And we share cases, we discuss them together, and we really put our heads together to try to understand how to best ensure that our patients are clear of C. diff, but it's not an easy answer.
So thanks, you guys. We have a bunch more questions, so I'm going to try to lightning round this, and I'm going to try to see if I can just answer a couple of them off the top, and then we'll refer the rest of them to you. Paul, we have a quick question about your Everything C. diff website, whether it's being continued. Somebody has found it very helpful. That feels like a yes or no question.
So yes, it's being continued. Yes, I would expect it to be updated in Q1 2024.
Thank you. So we have a question: what resources are available for the mental part of this battle? Seems like Kim has been through quite a few things. Kim, obviously, if you can get therapy, that's something that we are totally for. We also realize that many therapists will not understand what you've been through. So we have at Peggy Lillis Foundation started a peer support network. You can go to our website, you can sign up, and we pair you with somebody like Maryann. In fact, Maryann participates in that program. And it's someone who you can talk to. You know, this is not medical advice. This is not real, this is not psychotherapy, but it's like a buddy. It's someone who can tell you what they've been through, what they've gone through, direct you to more resources. So anybody who's on here, I know we have a lot of people that have recovered from C. diff on this call. If you're dealing with that kind of post-traumatic injury or mental or emotional issues, please go and apply. If you're somebody who's been through it and wants to be a peer supporter, that's something else we need more of. So keep that in mind too. Questions that seem related. We have a questions: do the new microbiome products have a role in antimicrobial stewardship programs? I don't know, Paul or Stacy.
Well, I would say at Boston Children's, I work very closely, and we have a C. difficile working group that includes pediatric GI, infectious disease, infection control, complex care, so individuals who have a lot of medical needs who are more likely to have C. diff, and as well as lab services and quality improvement. And we work together collaboratively to address this very issue, because it as I said before, it takes a village, and we absolutely all need to work together. And so I work closely with the antimicrobial stewardship group, and they track not only how much what antibiotics they're getting, but also how many patients are getting tested for C. diff and whether it's appropriate, because we don't want people to not get tested if they need to be tested as well. So that's a really important question. Thank you.
Yeah, no, we have a similar system at Yale that we're integrated into the Antimicrobial Stewardship Committee. And we certainly play a role in that piece. I think the live biotherapeutic product part of this question, that's more of a treatment of an after effect than it is integrated directly into the antimicrobial stewardship. So the stewardship is to prevent C. difficile, the live to prevent its onset initially or its onset in a recurrent form. The live biotherapeutic product, or RBL or VOS, these are products that are given right after a standard of care antibiotic to affect the immediacy of recurrence.
Thanks. This is, I think, is an important question. Somebody says, are any, and this one directly to me, Are any of these new medications, I think referring to VOS and RBL, offered to patients who have had recurrent C. diff, but they've recovered from it, like sometime post-infection? I'm not aware of that being the case, but Paul, Sahil, do you have a definitive word on that?
In the current state, the way those are being prescribed are what's in the label. You finish antibiotics, you have a washout period, and you get VOS or RBL. Right after that, I think if you've recovered from C. difficile a while back, then perhaps your microbiome is restored on its own, especially if you're eating more fruits and vegetables. Like Dr. Kahn mentioned earlier, have the rainbow color on your plate. I think for FMT, sometimes we use slightly different ways because we can do the reinforcement discretions. If I had a patient who had C. difficile and finished antibiotics 2 weeks ago, and we know they recur every 4 weeks, I would still be able to offer them FMT, but not Rebiota and VOS in current situation. Perhaps that will change in the future.
Oh, here's a question I don't know the answer to. So this Renuga got C. diff in the middle of pregnancy. Does this affect her unborn baby? Is the baby at risk taking antibiotics in the future?
A great question. I don't have an answer. Obviously, we want you to do what will protect your health, because the biggest risk to the baby is a risk to your health. So in general, that means that if your doctor thinks that antibiotics are indicated, whether it's C. diff or a pneumonia or some other viral infection that's quite serious, you should absolutely take the treatment, because we want to protect the developing fetus from the complications of these diseases, which are usually far worse.
The thing I will say in this realm is there's very limited data for the oral treatments of C. difficile, vancomycin and fidaxomicin in a pregnant patient. With that being said, both of these are what we call luminally active. So what you put into your mouth is essentially what you're passing out in your bowel movements. Therefore, with limited systemic absorption, and again, I have no data to back this up, but I'm just giving you theoretically what should happen. What you put in is what you get out. So it shouldn't be crossing the placental barrier and accessing the fetus. But again, I don't have data to support that. So obviously we need to always look at risk benefit, just as what was pointed out right before.
The only thing I would add to that is that if you go on our website, there are stories of people that have had C. diff while pregnant, including one of our advocates and peer supporters had C. diff during her most recent pregnancy, and both she and the baby are perfectly healthy and thriving now. So if that helps, the very nerve-wracking to be pregnant on top of having C. diff, I mean, a very scary situation. I know of at least 2 people who have had C. diff while pregnant. Does not seem to have complicated the pregnancy, once they were successfully treated. We are officially over time. I think we got to most of the questions. I think we did a good job, but I also want to be cognizant of our wonderful panel's time. I'm also getting hungry. It's 7:30 in New York. So I think we will sort of leave it there, unless folks have any last words from the panel that you'd like to leave the participants with.
So first of all, I think it's wonderful that everyone came out this evening or this afternoon, depending on where you are. We're at such an exciting time. I hope that you can see Stacy, Sahil, and my enthusiasm, because really the last decade has been formative for this infection, and the PeggyLillisFoundation has been really helping push the progress, and we are getting there. I mean, the conversation, the Q&A that we just had, we couldn't have had even a year ago. So I think it's really exciting.
Sahil, Stacy, Maryann, anything you any final thoughts?
I would say, Kristen, more than anything else, that we do as physicians in our offices, what you do and what our patients do for each other, and the help and support that our patients provide and the information that our patients can disseminate, there is no parallel to that. So I thank everybody on the call for being here.
Yeah, I would just echo what everybody said. And I was just looking through the chat questions, and there's one sort of more pressing question about whether stool samples need to be liquid, which I think bears answering before we leave, because it's really important. The FDA requires that the stool conform to the container, so a little plastic cup. So if it's totally solid, it should be rejected because the test is not valid. You should not be diluting your stool. Your physician should give you a stool kit, and or the lab should provide one. And if your stool is mostly formed and is getting rejected, that's a really good sign as doctors that we tend to be pretty happy about. So sorry to add one more question, and I'd also like to thank the panel who I learned so much from, and to Christian and the PeggyLillisFoundation for all of their support and advocacy.
Well, thank you. And thank you for grabbing that question. Oh, go ahead, Maryann.
Oh, I just want to thank the whole panel, because as a patient, I can't tell you how important it is, and just a heartfelt thank you to Stacy and Paul and Sahil. They're so driven about their patient suffering to find ways to treat them and to have a cure. And as a patient who suffered so much, I only wish that you had all been my doctors. So thank you. Thank you so much for the empathy that you show your patients. Thank you to the PeggyLillisFoundation for reaching out and making all of this possible, because when you're suffering and you're so sick and you don't know where to turn, at least there is Peggy Lillis that I didn't have at the time. Well, I wasn't aware of PeggyLillisFoundation at the time, but there's a great support network here. We've got great physicians working with us, and it is a very exciting time. So thank you to everyone.
And I would just like to say, before everyone hops off, thank you again to Nestle Health Science and Series Therapeutics for sponsoring this. There's a lot of work that goes on behind the scenes. I am so grateful to Maryann, to Sahil, to Stacy and Paul, not just for tonight, but for we've been working with these folks. Sahil's our most recent addition, but really agree with Maryann and saying that these are doctors that I would call and say, please treat me if I had C. diff. So driven, so invested, really does my heart good. I know my mom would like all of you enormously. And the other thing is that for folks who are on, if you're a C. diff survivor or family member, I'm going to pop it in the chat. If you want to become involved with PeggyLillisFoundation, we have our Advocates Council, we have our peer support network. Stacy mentioned we do need better diagnostics. We are always talking to diagnostic companies. We need more sort of basic science research, and that gets funded through NIH and stuff. So, we need people out there advocating, to fund and do, and make sure that this disease gets the attention it deserves, and that the resources are there for us to really make a difference. And we have made a difference. Things are way better than they were 13 years ago when we got started, thanks to these incredible physicians, but also thanks to Maryann and all of our advocates and everyone who's helped us along the way. So I'm very heartened by this. And thanks everyone so much. We are going to leave it there. And thanks again. I mean, it was great. Thank you so much, and get out there and help raise awareness during C. diff Awareness Month. Have a great night, everybody.
Thanks. Good night, everybody.
Thanks, Christian. Thanks, everyone.
Thank you.